I'm going to encourage each of you, when you find yourself at a decision-making table, your first job is going to have to be to look around and say, who is not here at this table who has an interest in this proceeding? And then your job is not just to represent their interest, but your job actually is to find them a way to the table. So structures are the who, what, when, and where of decision-making. Policies are the written how of decision-making. And again, we need to develop the discipline of seeing the absence of. Not only review the policies that are on the book, but what policies have put in place could make things better here. And then if policies are the written how of decision-making, practices and norms are the unwritten how of decision-making. Who gets named to a committee or tapped for that role? Sometimes that's harder for us to figure out what's going on there, but we must. And then values are the why of decision-making. And I used to be, thinking values was philosophy or religion. But values are very important for us to address. I know many of you may or may not be familiar with my Gardener's Tale allegory. I believe that there's going to be a copy of that 4-page paper available for you to read. But for those who are familiar with the Gardener's Tale already, I'm going to jump to a punchline here, which is, even if we were to compel that gardener to enrich the poor rocky soil until it was as rich as the rich fertile soil, if that gardener continued to prefer red over pink, that gardener will continue to privilege red over pink going forward. So it's not just about the opportunity structures, the quality of the soil that I used to always focus on, but we also need to address that gardener's initial preference for red over pink, which set up the whole situation. That cultural racism, if you will, that white supremacist ideology in our context. We must address those values if we're going to set things right in this nation. So I hope that you have a wonderful conference. I'm so delighted that I'm at least able to participate with you at this level. And I hope that you will not feel intimidated by the big questions. It's not something you have to do on your own. We are in a collective here, and together we can. Thank you very much.
Okay, so communications, I just want to confirm. I should redo this. Okay. Oh, I wish we could talk about that. That's probably like my third time watching it,
Hello,
and I just
everyone.
want.
This is Dr. Kamara Phyllis Jones. I'm delighted to be joining you at your conference where you're.
But I just feel so, I don't know, kind of beaten in a good way, sort of slapped into mobilization. But I feel like I can. You know what I mean? Like whatever she challenged us to do, I feel like it's doable. And I'm just so thankful to that she's here at Morehouse School of Medicine for this season. But just that we have someone like that in this space. But I just feel like it's inspirational that you guys are part of that solution. So I'm hoping that that comes across today. So because now we are welcoming our live stream audience, I get to read Tn's bio one more time. And I'm actually a minister, so you know how you do stuff in church. Let's welcome our national audience, and everybody goes, "No, just kidding, just kidding." That's what it made me think about. So, by way of introduction, Tyan Parker Dominguez, PhD, is a clinical professor in the USC Suzanne Workpeck School of Social Work and a research associate in the Center on Social Disparities in Health at the University of California, San Francisco. Her research focuses on persistent racial and ethnic disparities in adverse birth outcomes, with an emphasis on psychosocial health determinants, particularly stress and racism. I was going to try to skip down some. She also appears in the award-winning PBS documentary series, Unnatural Causes, Is Inequity Making Us Sick?, which was honored with the National Academies of Health Award for Outstanding Scientific TV Radio Programming. She also chairs and co-chairs many organizations, but the most important and profoundly gratifying title that she holds, however, is Mom. So with that introduction, let's welcome Tyan to the podium. How far can she roam? She must have moved.
Thank you very much for inviting me here to your conference on health equity and health disparities. I am really excited to be here with you this morning. I actually come from a little bit of a different world. I live in the maternal and child health world. I study disparities in adverse pregnancy outcomes and infant mortality, low birth weight, preterm delivery. So I'm not a chronic disease person, but the things that I study have implications for chronic disease. And so hopefully the remarks that I have to share with you today are going to be things that are going to be useful to you in the work that you all do, in terms of diabetes and chronic health disparities. I am also very much open to sort of this being a dialogue. So if there's any point where you have a question about something or a point of clarification or something like that, I'm happy to have you, interrupt me and ask me a question. I think we're going to be okay on time. So, little arrows at the bottom, there we go. Okay, so the objectives, what it is I'd like to accomplish with you this morning is to review with you the nation's public health priorities as delineated in Healthy People 2020. I'm sure most of you are familiar with what these are, but because we have an eclectic audience, we want to make sure that we're all sort of starting on the same page. And the ultimate point of my remarks this morning is to frame the key issues around disparity. What are some of the key sort of concepts when we think about trying to understand persistent racial disparities in health outcomes? What are some of the key concepts to be thinking about, the key sort of theoretical frameworks and that sort of thing? So we'll be starting looking at the nation's public health priorities. And then I will discuss social determinants of health as fundamental for understanding persistent racial disparities in health. And then I will present stress as a framework for how social inequity gets under the skin. And then lastly, I will offer just some general remarks about directions that we can take for closing the health gap. Okay, so Healthy People 2020 is the nation's public health plan. We do it every 10 years. We set 10-year sort of goals for what it is that we want to accomplish in terms of the health of our population. And so for the current public health plan that we are under, Healthy People 2020, so these are goals that we want to achieve for the population by 2020, the overall vision is to have a society in which all people live long and healthy lives. I think we can all agree that's a really good goal to have, right? Something to achieve. This is what we'd like. All people to live long and healthy lives. If we're setting that as a vision for our public health plan, that means that we don't have that right now, right? Not all people in our society are able to live long and healthy lives. So the goals for meeting this vision, how are we going to get to this vision? Uh-oh, I'm getting some Adobe Connect. There we go. The first is to achieve health equity. What do we mean by health equity? It's audience participation time. We want to achieve health equity in order to help us reach our vision of having a society in which all people live long and healthy lives. So what's health equity? Okay. Okay, equal access to health care, same rates of mortality, independent of racial background or socioeconomic status or that sort of thing. Okay, any other thoughts? Thank you. Okay. Okay, so she said to take into consideration differences so that you have to give everybody what they need in order to achieve the same goal. Right, so some people may need things that are different than other people in order to achieve their health goal, right? If we all want to live happy and healthy lives, what it takes to make me healthy may be different from what it takes to make you healthy, right? Okay, so health equity would be that each person would get sort of what they need to be healthy. Okay. All right. Any others? I think those are really good. All right, so we want to achieve health equity in order to help us reach our vision. We also want to eliminate disparities. What are disparities? Differences in the way we receive health care. Okay, so these would be healthcare disparities, differences in terms of like who gets what out of the healthcare system. Okay. Yes.
Thank you.
Oh, someone right behind you, but you can be next if you'd like. No, you're yes, please.
Differences in incidence, prevalence, mortality, morbidity of disease when it comes to everyone.
Okay, so differences in incidence, prevalence, mortality, and disease. Okay. And this gentleman right here, I think, wanted to say something. And then
The variability in oh, sorry. Okay, not used to that. Variability in social as well as cultural as well as economic, which underscores the issue of health disparities in many instances. Could be income, but it could also be wealth.
Okay. All right. So we're talking about, you said cultural differences, socioeconomic differences, income and wealth as distinct, right? Did you want to? Uh-huh.
I feel like I'm pretty loud, but all of those things that prevent us from having equity. So
Okay.
it could be our jobs, our income, our houses, our communities that we live in,
Okay.
access to those things.
Okay. So access to a variety of different sort of resources, right? Okay, good. So if we're thinking about, again, achieving this vision of all people living long and healthy lives, then we know that we have, well, Healthy People has set goals for achieving health equity, right? Eliminating health disparities, and improving the health of all groups across the board. So we have health disparities in that there are certain population groups who have higher incidence of adverse health outcomes than other population groups, right? But ultimately, we want everybody to enjoy good health. So everybody's health needs to be improved. All right. And we'll see in the United States, even though we spend the most of anybody on health care, we're the only industrialized nation without a universal system of health care. And even though we spend the most percentage, highest percentage of our GDP, gross domestic product, on health care, we do not have health outcomes in our population that would reflect that kind of financial investment. When you look at the health of our population on different indices compared to other countries, we do not stack up very well. So this goal of improving the health of everybody is really important for the country as a whole. Okay, so health equity, as I'm going to define them. And we're all on the same page, by the way. So health equity is that everybody has the same opportunity to be healthy. Everyone has the same opportunity to be healthy. Okay? Now, of course, what it is that you may do with those opportunities, could be up to you. There certainly is an element of sort of individual choice and individual, sort of responsibility for your own health, of course. But everybody should have access to the same opportunities in order to maximize their health. Health disparities are not simply health differences between population groups. When you think about health disparities, we're thinking about persistent, avoidable, and therefore unfair health differences between socially advantaged and socially disadvantaged groups. Health disparities are persistent, avoidable, and therefore unfair health differences between socially advantaged and socially disadvantaged groups. Health disparities occur because we do not have health equity. Not everyone in our country has the same opportunity to be healthy. And that difference gets manifested in health disparities, these persistent, avoidable differences that you see in health between socially advantaged and socially disadvantaged groups. And some people from the audience have already, when we were sort of talking about this, mentioned things like socioeconomic status, right? So people with fewer economic resources, we know there's a very strong correlation between health and your socioeconomic position, right, or your socioeconomic resources. So fewer resources you have, the worse off your health tends to be, for example. We also have a considerable amount of health disparities according to race, ethnicity, right? One of the strongest also predictors of health outcomes. Okay, this is, have any of you seen this before? Okay, so this is the work of Kamara Jones, and I just want to give sort of a nod to her. She's one of my heroes in the disparities world, I think, for a lot of us. She has just done a lot of groundbreaking work around racism and health, and really putting racism on a national stage, really making it something that we need to have a conversation about, right, on a national level. We have to be able to speak the truth. If we really are committed to achieving the vision of Healthy People 2020, then we have to be able to speak openly, honestly, clearly, and courageously about what are the factors that are fundamentally driving these persistent population health disparities that we see. So I'm going to quickly sort of walk you through this diagram here. But this is what she calls falling off the cliff of good health. And so she indicates sort of how we start from the fundamental drivers of population differences, which are the isms. Okay, we don't have health equity, everybody having the same opportunities to be healthy, because we don't have social equity. We do not have equal opportunities in this society for different population groups, right? Just period. And because we don't have equal opportunity or equal access to social resources, in order for people, regardless, of who you are, in order to achieve your, sort of own personal goals for well-being, social well-being, right? Everybody would like to have sufficient income, right? Sufficient resources in order to take care of yourself and of your family and sort of achieve goals that you have for yourself in life, right? Okay, so not everybody has that same opportunity. Because we don't have equal access to social resources, that means that that's also going to impact the access to opportunities for promoting our own health and well-being. So that's where understanding health disparities starts, with understanding social inequity. So we do not have social equity. So we end up having differences in access to social resources. And these differences are based on the different sort of isms, right? Racism, classism, sexism, homophobia. Think of all of those factors that separate us, right, within society. All of those factors that create hierarchies of opportunity in society. Those we have to really look at clearly dismantling if we want to be serious about achieving our health goals for our country. So because of this, because of these isms, we end up with different population groups having differences in opportunities and exposures. Opportunities are good things, right? There are resources that help you sort of achieve your goals. Exposures can be, I guess they can be both positive and negative, but we tend to think about exposures as being maybe things that may impact our health negatively. So if you don't have sufficient resources, then you may be more likely to be exposed to certain things that could be bad for your health, right? Okay, somebody over here earlier had said things like, when we were talking about health disparities and equity, had said things like transportation, for example, or access to jobs, or access to food, right, in your community, or things like that. So you may be more likely to be exposed to pollution, or be exposed to violent neighborhoods, or be exposed to food deserts because of lack of social equity. So we have differences in exposures and opportunities, which then also leaves us differences in terms of our vulnerability to adverse outcomes, adverse health outcomes. And so you can see we've got sort of our orange population and our green population, and they're at different points sort of on the top of this cliff. The green population is much closer to the edge of the cliff. So the green population probably has higher levels of exposure and higher levels of vulnerability to adverse health outcomes. And once they're right there at that edge of the cliff, you see that? There's nothing to stop them from going over, right? But on the orange population, you see that if they were to get to the edge of the cliff, there's actually like a little fence standing there that will protect them from falling over the edge. Green population doesn't have that. So if the green population sort of falls over, and they get sick, they fall over the cliff of good health, they get sick, then we're going to see differences in access to health care. Right? So you get sick, how are you going to get better? Well, if you don't have access to the resources to treat whatever illnesses that you have, right, or there's differential access, then you may have to wait to get the services that you need, or you may not have access to them at all, right? Assuming that you go to seek out those resources to maximize your health. So we also have to think about once people get sick. So we start off with sort of the social isms, right? That leads to sort of vulnerabilities, exposures, opportunities. So these are sort of things that we can look at in terms of prevention and early intervention. What can we do to keep people from falling off the cliff of good health? Some people already have things in place, like the orange population that's got a fence there to prevent them from going over. They may have access to things like primary care, where they can go regularly to get their health, sort of checked up and get things sort of caught early and addressed before they get sick. If they get sick, differences in access to care and differences in the quality of care that people receive. And I think that may have been something that you were sort of referring to earlier, accessing the healthcare system. What does access really look like if the quality of the care that you receive is substandard, right? So these are all things to sort of think about sort of along the path of understanding how we end up with population differences in health or health disparities. It starts with the fact that we have social inequity, which leads then to health inequity, which then leads to health disparities. But you can see that there are different points along the way that we can intervene, right? And we have tended to intervene after people fall over the cliff. We're real good at that. We spend a lot of money on that, right, in this country. But wouldn't it be great if we could keep people from falling off the cliff? That's health. You don't want to get sick. So that's what we want to focus on. Okay, I'm going to talk to you a little bit now about how these things that we've been talking about so far in terms of health equity, health disparities, those sorts of things, how they sort of relate to the work that I do in maternal and child health, and then I'll connect that to some things in chronic disease as well. So as I mentioned to you, I study racial disparities and adverse birth outcomes. I'm really very concerned about African American women's higher rates of preterm delivery, low birth weight, and infant death, and maternal mortality is probably the worst statistic that we have, maternal death in pregnancy. So infant mortality has actually been called the most sensitive index that we possess of social welfare. We think about infant mortality as an indicator of health, and it is, and it's an internationally recognized indicator of health. All of the countries use this as an indicator of the health of their populations, but it's been recognized as more of an indicator of how well that society is functioning as a society. How well are they doing in terms of taking care of the most vulnerable in their population? So, how are we doing? In the United States, 6 babies out of every 1,000 who are born alive will die before their first birthday. And that's a general definition of infant mortality, the death of a live-born infant within the first year of life. So here it's about 6 out of every 1,000 babies. So is that good? Is that bad? How are we doing in terms of, it seems like that doesn't seem like that's very many. In my mind, any baby dying within the first year of life is too many. But let's see. So although we spend more than anybody else on healthcare, we're really good at that, and although we have these lovely NICUs, neonatal intensive care units, that can save the smallest of babies, and I can attest to that, having had both of my pregnancies end in preterm delivery, having delivered babies that are low birth weight, I have a set of twins, so they're at higher risk for being born preterm anyway and low birth weight, but having had that NICU experience with them, I can talk from a personal, sort of point of view around that. Even though we have wonderful care in our hospitals for taking care of sick babies, again, we shouldn't have sick babies. The United States, our rate of 6 babies dying for every 1,000 that are born, ranks us behind 26 other industrialized countries. Our peer countries, we rank behind 26 of them, even though we outspend them by far in healthcare. If African Americans were their own country, they'd rank behind 91 other countries in infant death. African Americans have 2 times the rate of preterm delivery, low birth weight, and infant death of all other racial and ethnic groups in this country. And it's been that way for as long as we have recorded health statistics by race and ethnicity, which is well over a century. So think about all of the advances that we've had in healthcare, all of the advances we've had in public health, and we still sort of see this sort of persistent gap. Now it sort of ebbs and flows. Our infant mortality rates sort of go up and down, but that gap tends to remain stubbornly persistent, and that gap is the health disparity gap. So in trying to understand infant mortality, what is sort of what are the main drivers of infant mortality in the United States? Because it's different, in different countries. Here, it's our rates of preterm delivery, a baby born too soon, and low birth weight, a baby that's born too small. Those are the leading causes of infant death behind congenital anomalies, which is the number 1 cause of infant death in our country. So we've got 2 times the rate of adverse birth outcomes among African American women compared to everybody else as well. So they're delivering babies too soon, they're delivering babies that are too small, which puts them at much higher risk for having their babies die within the first year of life. And these birth outcomes have implications, not just for the health of the baby within that first year or even within early childhood, but across the entire life course. These are things that can set a child on a health trajectory across their life course that could increase the risk of chronic disease when they get into adulthood. In childhood, we know that a baby that's born too small or born too early is a much higher risk for a variety of sort of health and developmental issues, which is something that we could all sort of, we would assume. But in adulthood, these adverse birth outcomes have also been associated with cardiovascular disease, with diabetes, with hypertension, and even with dementia in older adults. So they have major implications across the life course. And we're going to come back to that life course issue in a little bit. So in trying to understand disparities in adverse birth outcomes, there we go. In adverse birth outcomes and infant mortality, and thinking about what sort of explains it. Why is it that African American women are at higher risk for these things? All of the traditional risk factors that we might think about, like prenatal care, for example, or medical risk, a woman sort of enters a pregnancy and she has a pre-existing health condition that puts her at high risk, or she develops one during the course of a pregnancy. Or maybe it's health behavior. I already mentioned to you, like prenatal care or smoking or, or substance use or things like that. Or socioeconomic status. We've already mentioned that there's a very strong correlation between your socioeconomic position and your health outcome, right? Well, when we take into account all of these factors for the sort of the researchers in the room, when you sort of control for these factors in like a regression model or something like that, the sort of race is still a significant predictor. So there's something unique about being African American that is related to this higher risk of adverse birth outcomes. And in fact, some of the things that we think about that put people at higher risk are sort of paradoxical. For example, white women are more likely to smoke during the course of pregnancy than black women are. And there's also a misconception that black women don't get into prenatal care early enough. But that's not true either. They're getting into prenatal care in that first trimester, 75% of women. Socioeconomic status. We actually see the biggest gaps in adverse birth outcomes at the highest levels of socioeconomic position, which is completely the opposite of what you would expect, right? Better socioeconomic position, higher education, more income, those sorts of things. That should be protective of your health. The gap should close. It gets bigger. So there's a puzzle about trying to understand the factors that are contributing, but we know that it's not sort of this thing around socioeconomics where people automatically sort of equate race and SES, or socioeconomic position, right? If you're a person of color, you're automatically low income, right, or something like that. We tend to have that mindset. But the data shows that even at higher levels of socioeconomic position, there is higher sort of vulnerability around health outcomes. So the next sort of thing that comes up is, well, maybe there's something genetic going on. If it's not all the traditional risk factors that we know, we can't explain it away with that, and it's not socioeconomic position, then maybe black women are just sort of wired differently. There's just something about them that predisposes them to having an adverse birth outcome, being more vulnerable during the course of pregnancy. But the data does not support that sort of conclusion either. This is actually a graph from a study that was done out of Chicago by another set of my heroes, James Collins and Dick David, who looked at vital statistics records in Illinois, comparing the birth weight distributions of African-born black women, U.S.-born black women, and U.S.-born white women. Okay? And what they found is that the birth weight distributions of African-born black women and non-Hispanic white women were virtually overlapping. But the birth weight distribution for the African American women was significantly shifted downward. So there is something about being a black woman in the United States, right? Living your whole life here, that is not good for your health. And what we know in looking at immigrant populations, they tend to be healthier when they get here. But once they stay a while, if they are populations of color, you don't see the same patterns when you're looking at European immigrants or Canadian immigrants. You see this with populations of color. The longer they are here, the worse their health tends to get. And they also did a study, Collins and David, which actually looked at the birth outcomes of the daughters born to immigrant black women. The daughters born to them when they have their babies here, daughters who are raised here, who have their babies here. And their birth outcome distribution was shifted down more toward the African American distribution. So in just one generation. So they concluded that there's something about the context. There's something about the social context that is not good for African Americans' reproductive health. And so this gets us into some concepts that sort of apply across the board, not just in maternal and child health, but in looking at health disparities in general. The ecological paradigm. This was probably one of the most famous sort of theorist around this is Yuri Bronfenbrenner, a developmental psychologist, and he talked about the importance of our being embedded in a social environment and the very strong influence that that has on our health and well-being. You cannot separate the person from the environment, right? We are born into community, and we are raised within community across our life course. And all of those things that we experience in our environment have an influence on our health and well-being. So that's the ecological paradigm. And that's what really what undergirds the social determinants of health. So how many of you have heard social determinants of health before? That's like the big buzzword, right? Social determinants of health. So social determinants of health has to do with all those factors that characterize the context of our lives. They are determinants of ourself that lie outside of our individual genetics, that lies outside of sort of our individual health behaviors. It's the context in which we live that we have to think about having an impact on our health. Okay, and if we go back to that falling off the cliff of good health schematic earlier, right? The sort of the context was front and center. The social context, those isms, right? Social inequity. So this is where the social determinants of health come in. Looking at those contextual factors about the nature of the context of our lives that impact our health. And we know that they're different, right? They're different based on social inequity. They're different based on health inequity. So I'm going to sort of highlight a few of the social determinants of health as they relate to health disparities, and particularly in the work that I do. So racism is at the top of the list. As Kamara had mentioned in her videotaped comments earlier, racism is fundamental to understanding sort of the way in which health is distributed across populations in this country. It's not an accident that people of color tend to have worse health than non-Hispanic whites, right? The majority population in this country. Racism has been defined as a pervasive system of social stratification and structures that structures opportunity and assigns value based on race, which unfairly advantages some and unfairly disadvantages others based on ideological notions of inherent superiority and inferiority. So this idea of thinking about racism in terms of not only oppression, but privilege is very important. We tend to think about racism in one way, the oppressed, right? But you can't have an oppressed if you don't have an oppressor. You have to think about both sides of the equation. And privilege can be a hard thing to think about for everybody. And everybody has privilege. You all did the IAT test earlier where you were sort of looking at your unconscious biases, right? I would encourage you to not only sort of think about your unconscious biases, be sort of cognizant of them and sort of keep them in mind as you walk around your world when they start to pop up for you. You know, as you're aware of them and they start to pop up for you, really think about what's sort of triggering that assumption that you just made about that person that you just saw, for example, right? You want to sort of check yourself around those things. That idea of raising your self-awareness is absolutely key, and for all of us, because we're all walking around with the disease of racism, right? We all drank the Kool-Aid. And if you have any question about that, look at young children who, without being taught, just sort of develop these stereotypes, develop these prejudices. There have been sort of the famous baby doll test, right, from the 1950s around Brown versus Board of Education, which all of us sort of know about, right, with sort of the black children having a preference for the white baby doll. But there are much more recent contemporary studies that also verify that this is still very much the case. So we have to think about both sides, unfair advantage and unfair disadvantage that comes from racism. And racism is not about how you look. It's about the meaning that comes along with how you look. How do people interpret that? What meaning does it have, right, that you have darker skin, or that your hair texture is a little bit different, or that your nose is a little narrower or something? What does that mean? It holds social meaning, and that's what it is that we really need to sort of get at. Why do we think that that's important? Because if you look across a whole variety of different academic disciplines, they are all in agreement that race is not a biological factor. This is something that we made up. There's actually, I don't know how many of you have seen it, there's actually just this past week a write-up in, I think it was the New York Times, of a study that was just published in Science, a very high-tier journal, looking at the genetic, human genetic variation in skin color, which basically the upshot was that we have made a profound error if we think that race is biological. So this is something else, raising our level of awareness and understanding. We've sort of come up with all sorts of these delusions around what race is and its significance, right? That it's something biologically meaningful, that it has something, and so because if that's the case, right, if these birth outcomes, for example, disparities, were genetic, then there's something flawed about Black women, right? There's something flawed about the population, the African American population. Pick your health outcome. They're at the top of the list at having sort of, some of the worst outcomes. And our Native American population. Let's not forget about our American Indian population, because they often do get forgotten. But their health outcomes also are not very good. And think about historically the sociopolitical history around what has happened to our American Indian population, right? And the sociopolitical history about what has happened to our African American population, and so on and so on. Unpacking the invisible knapsack. This is getting at white privilege. Peggy McIntosh, how many of you have heard about unpacking the invisible knapsack? A couple of you. All right. So she talks about this idea of white skin privilege. White skin in the United States opens many doors for whites, whether or not we approve of the way that dominance has been conferred upon us. She is a white woman. The silences and denials surrounding privilege keep the thinking about equality or equity incomplete, maintaining the myth of meritocracy, the myth that democratic choice is equally available to all. See, when you have privilege, you don't recognize that you have privilege, usually. It just is. It's just you're normal, right? You don't recognize when you have privilege, and it often then makes it difficult for you to recognize when others don't have it, because it's your normal state of being. And so if you see other people that aren't functioning sort of at the same level you are, then there must be something wrong with them. It doesn't have anything to do with what you may have, any advantages that you may have, because you may not even recognize that you have advantages. But all of us do. Right? All of us, think about if you're sitting in this room, more than likely you're pretty highly educated. That's a privilege, right? That gives you access to information and to resources that other people don't have. So one of the other things in raising your self-awareness, not only around your own unconscious bias and your own privilege, is also around how do you or do you not use your privilege in order to help those who don't have it. How are you opening doors of access when we know not everybody has the same access? When you are at a decision-making table, as Kamara had mentioned, do you notice who is there and who isn't? Or is that not something that ever crosses your mind? That's one of the things that those of us who do have privilege, who do have access, we need to take on responsibility for opening that access to other people, think about that in your own sort of world, in your own everyday life. What are ways that you can use your privilege? You got to recognize it first, right? But use your privilege in order to make life better for somebody else. How can you be a champion, right? How can you promote health equity in your world simply by utilizing your privilege, leveraging it for the greater good? Okay, racism, that's what we were talking about. Racism may manifest a variety of different ways. Attitudes, beliefs, actions. We think about this in terms of prejudice, stereotypes, discrimination. And if those of you who are familiar with Kamara Jones's work around the gardener's tale, right, her allegory to really help to explain different levels of racism. Racism also operates, it's multidimensional, it operates at institutional levels when we think about sort of our structures, our policies, our institutions, an interpersonal level, which is the level at which most people think about racism, right? Between two people, somebody called you, sort of a derogatory name or something like that, or ignored you when you walked into a store, or followed you as you walked around a store, right? Or you're standing right in front of them and they just don't see you there, right? We've all had, well, some of us have had those experiences. Interpersonal racism. And then internalized racism. What's internalized racism?
You tend to, as a black person, might tend to think black is wrong or black is inferior. That even if you are a black person, that you don't have the same rights or the same advantages because you are black. You're kind of internalizing the, I guess, majority opinion.
Okay. So you internalize sort of the negative stereotypes about your group, right? And is it something that you do sort of consciously that you sort of say, oh, okay, I'll accept that. I understand that. I got it. Good. Not really. No. This is all part of sort of the disease of racism. It's sort of a silent killer, right? It's one of those things that we're born into it. We're born into it. It is part and parcel of the air that we breathe, and we just sort of take it in, right? That's why you'll see little kids, they're new to the planet. They're paying attention. They are paying attention to everything, and they pick it up very quickly. Who's, just watch little kids play on the playground. Who is it that's the bad guy? Or the one that has to sort of chase everybody? Who's getting excluded? Right? And so, and I have stories that I could share from people coming up and sharing their stories with me. But in the interest of time, I'm happy to share them later. But we've got to move on. But this idea of internalized racism is very important because that impacts the self-esteem of people who believe that they are inferior. Now, if you ask them that, they wouldn't say that. You're not necessarily conscious of it. But in terms of sort of attitudes or behavioral patterns, for example, there are color hierarchies within groups of color, right? You know what I'm talking about. The light versus the dark skin, or in everything sort of in between. And somehow, we've come up with these ways of treating each other based on skin color. We do it. We do it to ourselves. Where do you think that comes from? Why is it that we have these notions of beauty within our own populations? These notions of beauty that the more that you sort of look like sort of a European model of beauty, the more, in fact, beautiful that you are. And then also maybe the more intelligent you are, the more capable you are, the more potential you have, all of those sorts of things that go along with that. And the divisiveness within our own communities that's born of that. The divisiveness. Again, we drank the Kool-Aid, right? That's internalized racism. All right, and there's a really great little video about this too, another demonstration. How many of you have seen this, A Girl Like Me? I highly recommend it. You can YouTube it. It's A Girl Like Me. It was done by a 16-year-old young woman, African-American young woman in New York. She simply interviewed her friends about things like, you know, getting married one day and having kids and their experiences, you know, with their own moms around, their hair, black hair. That's a whole other conversation that we could have, right? But, you know, just talking to her friends. And the instances of internalized racism that come up really can bring you to tears. How these young women in this day and age sort of perceive themselves and sort of the things that they do or that other people may do, like what parents may do, around sort of these issues of a sense of there's something inherently wrong about you because you are who you are, because you look like you look. So I would recommend that. It's only about like 7 or 8 minutes. Very quickly, I wanted to let you know that I've been sort of talking about racism as a concept, but there is empirical evidence that links racism to adverse health outcomes. There's a lot of research that has been done around this, and Disparities has done the top 2 sort of wholesale reviews of the literature around racism and health. And so I just have here sort of some of the typical features of these studies. That they tend to be done in the United States. Racism is sort of a legacy that we own to a great degree. And so a lot of research in racism gets done here, and it predominantly is around African Americans. And if there tends to be a comparison group, it's usually with non-Hispanic whites. Adults have been studied the most often, although there is a smaller literature around children's experiences of racism and the impact on their health development, school performance, identity development, those sorts of things. Women tend to be overrepresented in these samples, cross-sectional designs, those sorts of things. Negative mental health outcomes. Mental health has been probably the outcome that has been the most studied in association with racism, but certainly health outcomes. And these are some of the health outcomes that have been linked to racism. You see all the emotional and mental health things on one side, but in terms of physical health, racism has been associated with blood pressure, breast cancer incidence, hypertension, the birth outcomes that I mentioned to you, heart rate, obesity, overweight, self-reported health status, mortality, cervical cancer screening, how often you go to the doctor, and health behaviors. The racial wealth gap. This is another part of social determinants of health. We've got sort of the racism. Racism is very much, or race is very much connected to class in this particular country, and we have a class issue in this country. And it's getting worse. Where is our middle class going? They're going to the lower class. That's where they're going, right? We have this increasingly divide between the rich and the poor. And when you look at it by race, we also have a big divide in class by race. And you can see this is wealth. Somebody had mentioned this earlier, right? Wealth versus like income. What is wealth? I'll ask you since you raised it. Yeah. Oh, yeah.
All your assets.
Mm-hmm.
And most of those assets in the United States are comprised of ownership of property, home ownership. And that's defined wealth. And according, this looks, so basically for every white dollar in wealth, there's 10 cents for African American. And that's what he spells out in his book, Toxic Inequality. And whereas income actually has apparently improved. The gap is shortened. It's about 60 cents to the dollar, white dollar versus African American income. So this is what he's most concerned about, is this wealth gap. And you just said the bottom's dropping out of the middle class. And the rich get richer, and that's often by privilege
Mhm.
and by just exactly what you've been saying. I
Mhm.
mean, for me, I'm in public health, and I didn't think about wealth that way, but it's incredible. And then I'm reminded of coming from LA. I grew up in Inglewood, California,
Uh-huh.
of redlining and
Mhm.
those kinds of practices.
Right.
Why my African American classmates couldn't live in the same neighborhood I could,
Mhm.
that kind of thing. That this all spells in it. He does a good. So anyway,
Right.
yeah, thank you for
Sure.
asking me about that.
Oh, sure. I'm glad that I did, because I mean, you heard Thomas Shapiro. He's legendary around this stuff. So yeah. Mhm. Sure. Uh-huh.
Knowing how to manage your income
Mhm.
and just having access to it, that there's
Mhm.
a lot that goes into what we're saying. I don't know if you were going to deal with education or if that
Mhm.
will come out today. There are some educators in the room.
Mhm.
So very, very important in this question of equity.
Right. No, I think that that's a really good point that you raise. And again, we sort of talk about access to opportunities, right? When we were talking about what is equity, right? Having access to opportunity. Well, education around wealth, for example, right? Well, what do I do with my money? How do I manage, my earnings? I may be earning at a level almost kind of commensurate, right, with the majority population, but do I know what to do with my earnings in order to sort of secure my financial future and my family's financial future? Am I educated around how wealth works in the United States, how the economic system sort of works? And you mentioned home ownership as being sort of foundational to wealth development in the United States. And if you look at sort of the history around racism, institutionalized racism around access to opportunities to home ownership, that's not a big leap to understand why there would be these huge differences in wealth. Wealth are your assets. If you stop making a paycheck, right, how long are you going to be able to continue living in your home? How long are you going to be able to continue feeding your family? Well, that's going to depend on what are your assets. Do you have assets that you can tap into, right, if that paycheck stops for a little while? Or is that going to be it for you, right? How many people, when we had the the latest economic recession, right, they lost their homes and that was it, because their home was their asset, right? And that was it. So this is a really big deal. This is how people transfer higher socioeconomic position or even middle class position across generations. You don't have to start all over again, with each new generation. With the African American population, because of sort of the barriers, just as an example, I'm not saying that only the African American population has experienced this, but as an example, because of discrimination around access to opportunities to own homes, the typical path towards higher social mobility or higher social economic position is education, right? So you achieve in your own sort of lifetime. You may have been born into more meager circumstances, but you worked really hard and your parents really pushed education and you sort of hit the books, you did well, you achieved, and you were able to, through education, achieve a track into the middle class or sort of the upper middle class, right? But then what do you do once you start earning that paycheck? Do you know how to manage that income, right? Transfer it into wealth in order so that your kids don't have to start all over again. That's what keeps sort of the white middle class and the white upper class intact, because they have assets and they pass them on and they got a head start in accumulating those assets. Okay, this is just another one around the racial wealth gap. You just see it's really big. Okay, so I've already sort of hit on this: social policies, which have limited ability of people of color to accumulate wealth, particularly through home ownership, less intergenerational wealth transfer because we don't have assets to transfer, right? Higher costs to borrow and to insure. It's not just what you do with your money, do you know how to manage your money, but we're also paying more. We pay more to borrow money from banks, for example. We have much higher interest rates, much higher rates around insurance, much higher demands on the income that we do have. More than likely, we are helping other people along, right? Helping family members or things like that. If we're doing well, there tend to be more demands on the income that's coming in. Educational opportunities are constrained. You may have to work really, really hard, but you may be going to substandard public schools, right, and working really, really hard. And then income incongruity. I don't know if this had been mentioned earlier, but this is the idea that for a given level of education, the earnings that come with that may not be the same for a person of color as it is for a person in the majority group. Okay, stress. I'm going to jump ahead in the interest of time. Okay, so I'm going to jump ahead and looking at intersecting oppressions. So we've been talking about racism, we talked a little bit about classism, and then we also have another ism, sexism. And this is particularly in the work that I do around maternal and child health and pregnancy outcomes and things like that. Looking at women in particular is something of, that's the focus of the work that I do. And when you look at the literature on racism and health, women tend to be sort of really well represented in those samples that are being studied. But we have to understand how all these sort of things sort of come together to cause an intersection of multiple sort of oppressions that people have to deal with. Multiple sort of challenges, isms in their lives that can block opportunities for them just in terms of living, right, and achieving their own personal or family goals or that sort of thing, but also in terms of their health outcomes. And African American women report very high levels of stress, higher levels of stress when you look at it in comparison. Pregnant African American women, for example, higher levels of stress. The life course perspective, I'm sure most of you have heard about the life course perspective, right? Okay, so the life course perspective, popularized by Michael Liu, who is now the director of the Maternal and Child Health Bureau for the U.S. Department of Health and Human Services. This is a model which helps us sort of understand how the context in which we live, that ecological perspective, right, and those social determinants of health, how we really have to understand how these intersecting oppressions around social inequity operate across the life course. We tend to think about sort of whatever our disease speciality is, we think in silos around that, right? I'm a diabetes person, so I'm only sort of thinking about, sort of maybe children with diabetes, but adults with diabetes, and just sort of all those things that sort of connect with diabetes. I'm a maternal child health person. I just sort of think about, those reproductive outcomes and those sorts of things. But we sort of have to understand that if we want to improve health outcomes, we can't start when the health issue gets diagnosed. If we want to be able to address health disparities, we want to be able to improve population health, we have to understand that health begins even before you're born. Health begins sort of with intergenerational sort of factors, right, that lead into that may impact your sort of circumstances upon birth, and then all of the different life experiences that you have over the course of your life, all of the different social determinants of health that, sort of come into play in your life, all of the issues of access and opportunity and exposures and those sorts of things that happen over time. The theory is that people of color or disenfranchised populations have more risk factors over the course of their life course that put them at higher risk for developing an adverse health outcome or an adverse sort of health situation than those who are privileged. And if we're looking at sort of race as the point of distinction, we can look at the non-Hispanic white population that may tend to have more opportunities, more privilege, more access, right? So if they do come in contact with a risk factor, they may end up having more resources to manage that risk factor so that risk factor actually doesn't turn into a problem in terms of their health, right? They may have more protective factors to sort of push the level of their health trajectory up, whereas disenfranchised populations have more risk factors, fewer protections, fewer sort of resources in order to manage risk should they arise. So with life course theory, the things to sort of keep in mind is the timeline. You need to think about health along this continuum. And that's why I think around the maternal and child health outcomes, like I mentioned, how babies start off and that connection between their birth outcome and their later risk for health and disease across the life course. It's not just sort of that initial year of life that we need to be thinking about. This is a long-term thing. If we're thinking about wanting to manage chronic disease and close chronic disease gaps, maybe we need to be looking a little bit earlier in the life course around sort of prevention and early intervention. So timeline is really important. Timing, critical periods of development. What is happening during those critical periods when things are happening, critical transitions in the life course, right? Those are times, think about critical times that we could intervene to really make an impact. And then environment, the role of the environment, the social environment is critically important when we think about a life course perspective and, of course, equity. This life course perspective that Lou and Halfon came up with was around trying to understand these persistent racial disparities in adverse birth outcomes. How can we understand these equity issues, these issues around access and opportunity? We think about it within this context of environmental exposures and protections across the life course. And stress, and this is the last sort of point I think I have time to make, is a paradigm that we could utilize to try to understand how the social environment, how social inequity, how that sort of gets under our skin. What are the mechanisms by which our sort of social experiences turn into physiological processes that put us at higher risk for adverse health outcomes? So stress has been defined as life demands or challenges that tax our adaptive capacity. And because of that, they increase our health risk. So all of us have sort of a stress adaptation process, right? The fight or flight response. This is a totally adaptive process. It keeps us from sort of being, keeps us surviving, actually, right? We have sort of the threat perception in our brain whenever there's a challenge or a threat in our environment that sort of kicks on our stress response, and we sort of go into action to sort of manage that or cope with that sort of stress. And once we've sort of managed it, then our physiological system, our stress response system, sort of goes back down to a normal level. Well, what if the threat never passes? What if it's constantly there and you're living under chronic threat, right? So we can think about these intersecting oppressions of racism, for example, sexism, classism, homophobia. Pick your choice, your access of oppression, right? Whatever it is. That chronic threat doesn't go away. It's always there. And I'm not going to have time to sort of get to the findings of research that I've done around this, but I have worked collaboratively with Amani Nuru-Jeter and Paula Braidman, part of that social research center at UCSF. And we did a qualitative study asking, African American women about their experiences of racism. And they talked about actively having to prepare themselves every single day for the likelihood that racism was going to happen, and how stressful that was. That idea of having, and they talked about not only psychologically having to prepare, but physically. They talked about physically feeling it in their body, the stress of just, I've got to go back out there again today. What are they going to say again today? And kids, that was one of the biggest concerns. How are their kids being treated? That's a huge stress for African American women. How are their kids, and I'd say African American parents, how are their children being treated? Particularly within the school system. That can be a whole other conversation too. Prison, sort of the school to prison pipeline and all of that sort of thing. But these are chronic stressors. Stress is not good for your body. It affects multiple systems within your body adversely. Particularly chronic stress, it doesn't go away. Your sort of stress response system remains sort of chronically engaged. And over time, that can lead to wear and tear on your body's adaptive processes. This is called allostatic load. You may have heard about this term. So the normal sort of stress response process, you sort of threat, you respond, your body sort of returns back to a normal level of functioning. With allostatic load, it's sort of that wear and tear that happens to your body over time from exposure to chronic stress, where the threat doesn't go away. It's like your foot, your body's sort of foot is on the pedal, the gas pedal, and it never lets up. So what's going to happen to your body's engine after a while? It's going to start wearing down, right? That's allostatic load. When that happens, you're at much higher risk for an adverse health outcome. And there are studies that have sort of looked at, I've listed some here for you, that have sort of looked at this concept of allostatic load and its relationship to Black